Our next section is endocarditis, infections of the interior of the heart. Now, endocarditis is a very unusual disease, very rare disease. Now, the first thing is that all we need to have endocarditis is a fever and a murmur, and a murmur and a fever, and a fever and a murmur, and a murmur and a fever, and a fever and a murmur, and a murmur and a fever, and a fever and a murmur, and a murmur and a fever. Fever and a murmur and a murmur and a fever is enough for to say we have endocarditis. Now, if they say a fever and a fever and a change and a murmur. If we throw in a risk, like injection drug use, or a prosthetic valve, woo-hoo-hoo, pretest likelihood of disease. Okay, now fever and a murmur is enough by itself. Now let's take a look at some of these slides here. If we look at some of the findings that you see in endocarditis, what we see here is Janeway lesions. Now Janeway lesions here are flat and painless, flat and painless, flat and painless, flat and painless. Now, Janeway lesions are very unusual, and you don't find them most of the time, Janeway lesions. Matter of fact, Janeway lesions probably present in less than 10 to 15% of patients, flat and painless, embolic phenomena into the skin. They don't hurt, they're there, like a Roth spot of your hands and foot. Now, you see, this is an Osler's node. For Osler's nodes, you'd have to be told that this is painful and raised. See this thing under the fingernail looks like a splinter? Well, splinter hemorrhages. But you see, Osler was writing about endocarditis when it was 1889. Now, Osler lived 50 years before the invention of the antibiotics. You know, Osler I shouldn't say invented, but started residencies in the United States, form of training that you're studying to enter. He started that, Johns Hopkins, 110 years ago, 115 years ago, 1890, 1892, Johns Hopkins. There was no residency prior to that. People would finish medical school, go straight out and practice. 4 years of medical school, you're done. It was like dental school. You finish your couple of years, you're out, you're done, you go to practice. Osler invented residencies and wrote the first modern textbook of medicine, 700 pages by itself. Do you know that plague has a 30% mortality? Tuberculosis has a 5%, less than 5% mortality. 2 billion people in the world have been exposed to tuberculosis. There's 2 billion PPD positive people in the world. Hantavirus, 60% mortality. Ebola, 80 to 85%. Ebola Marburg virus, 80 to 85% mortality. AIDS, 95% mortality. It may take you 10 years to get there, but 95% mortality. But do you know that the only infectious disease in that book that has 100% mortality is endocarditis? It may take a while to get there, but untreated endocarditis was, for the 19th century man, the equivalent of metastatic lung cancer. For the Janeways, for the Osler, for Roth spots looking at his eye, for Janeway, for Osler, for Roth, for Splinter, these were the signs of metastatic infectious cancer. What could we do about metastatic cancer? We can give you chemotherapy and then you die anyway, in many cases. Hard to show an extension of survival. The same thing with endocarditis. There was nothing that could be done. You could give them aspirin for the fever, codeine for the cough, but essentially, Janeway, Osler, Roth, all these findings were findings of untreated long-term endocarditis. Do you know how you died in the pre-antibiotic era of endocarditis? If you didn't treat anybody with endocarditis, with antibiotics, what would you die of? And it's not heart failure. Heart failure is the most common wrong answer. What you would die of with endocarditis is you would die of post-infectious glomerulonephritis. Glomerulonephritis because the infection causes antibody responses which clog up your kidneys, and the same way you and I think of post-streptococcal glomerulonephritis, well, post-infectious glomerulonephritis was the most common cause of death. These findings of Janeway lesions, Osler's nodes, Roth spots, splinter hemorrhages, these things now are irrelevant to us except for one thing. People who have negative blood cultures, how would you diagnose endocarditis? So, if we look at the person who has a fever and a murmur, and a fever, endocarditis for us, in terms of its diagnostics, is very simple. You see a person who has a fever and a murmur, and the best initial test is to look for endocarditis. The first test, best initial test, is blood cultures. The most common wrong answer is to say an echocardiogram. Do not do the echo first, do the blood cultures first. blood cultures are 95 to 99% sensitive. In other words, for every 100 people with endocarditis, 95 to 99% will have positive blood cultures. Only 1 to 5% will have a negative blood culture. Well, how do you diagnose endocarditis if the culture is negative? And that's where these come in. If you have a risk and a fever and embolic phenomena, if you have culture negative, a risk and a fever and embolic phenomena combined with an echocardiogram, transthoracic echo, negative blood cultures, if you have a risk and a fever and embolic phenomena, that's how you substitute for blood cultures. Transthoracic echo is not first because that test only has a 60% sensitivity. You can't have the best initial test being a test that misses 40% of your disease. The best initial test is blood cultures. If the blood cultures are positive, transthoracic echo. The transesophageal echo has a 95% sensitivity. However, generally it's not first. Positive blood cultures plus a positive echo equals the diagnosis of endocarditis. And you are done. Now, if you have negative blood cultures, fever plus risk plus embolic phenomena is how you would diagnose endocarditis. Now, the empiric therapy, while you're waiting for the culture and sensitivity, generally speaking, is vancomycin and gentamicin. Vancomycin is because staph and strep are the most common organisms. Gentamicin because there's a small percentage that have gram-negative rods, and because gentamicin, although it is predominantly a gram-negative drug, has synergy against staphylococcus. Vancomycin is often a cell wall agent. Penicillin is definitely a cell wall agent. It punches a hole in the cell wall. And then once more into the breach, dear friends, once more, and we'll close up the wall with our English dead. The penicillin punches a hole in the wall, and then the aminoglycoside rushes through the hole in the wall and kills the ribosome. And that's the basis of synergy. That is the basis of synergy. Vancomycin and gentamicin. Punch a hole in the cell wall, and the aminoglycoside rushes through the breach and kills the ribosome. Now, once you have a specific organism, you switch. Once you have a specific organism, once you know that it's a sensitive staph, once you know that it's a sensitive staphylococcus, then we switch. Then we switch to oxacillin, cloxacillin, dicloxacillin, and nafacillin, ox and naf. Well, if it continues to be methicillin-resistant Staph aureus, then we would use vancomycin, linezolid, daptomycin. Well, what would you do if it was a sensitive viridans group strep? And viridans group strep was treated with penicillin or ceftriaxone 20 years ago, and it's treated with penicillin or ceftriaxone now. Remember that the standard length of therapy for endocarditis is 4 weeks. If you have a resistant organism like MRSA or Enterococcus, it goes to 6 weeks. Resistant to 6, sensitive for 4. Resistant to 6 and sensitive for 4. What will you do differently if the person grows Streptococcus bovis? Strep bovis. When you see bovis, what will you do differently? And the answer is endoscopy. Endoscopy. Streptococcus bovis is associated with colonic pathology. So if we grow strep bovis, we will do endoscopy because it's associated with colonic cancer, with diverticuli and colon pathology. When you see bovis, it's time to scope. Finally, what is the single strongest indication for surgery in the management of endocarditis? What is the single strongest indication for surgery in the management of endocarditis? And the answer is congestive failure. Now, it is true that fungal endocarditis does better with surgery. It's true that prosthetic valve endocarditis does better with surgery, probably. It is true that abscesses need to be drained. It is true that people who continue to have recurrent embolic phenomena and very large vegetations should do better with surgery. However, you can treat fungus and prosthetic and abscesses and emboli with prolonged antibiotics, but no matter how long you treat antibiotics, you're not going to reverse congestive failure. No matter how long you treat with antibiotics, you're not going to be able to reverse congestive failure. No matter how long you treat with antibiotics, you're not going to be able to reverse congestive heart failure. Congestive heart failure. No matter how long you treat, you cannot reverse it. Congestive heart failure is the single strongest indication for surgery. So that means that we've taken endocarditis, we've reduced it down to something very simplistic. A fever and a murmur and a murmur and a fever and a fever and a murmur and a murmur and a fever. Get me some blood cultures, and if the blood cultures are positive, get an echo. Transesophageal echocardiography is far more sensitive. And transesophageal echocardiography is far more sensitive based on the anatomy. If this is the anterior and posterior chest, if you look at the anatomy, you will see that the esophagus, which goes right past the back of the heart, is much better for looking at what is the most posterior structure in the heart, which is the left atrium. The left atrium is the most posterior structure in the heart. And the transesophageal echo is much better for looking at that. The transesophageal echo and the posterior structure of the heart. Now, positive blood cultures and a positive echo equals endocarditis diagnosis. If the blood cultures are negative, you use a risk and a fever and embolic phenomenon. Vancomycin and gentamicin is the best empiric therapy until you have the results of your culture. Now, that's the easiest part. The more confusing and irritating part is endocarditis prophylaxis. Now, endocarditis prophylaxis is more difficult because endocarditis prophylaxis is divided up into so many subcategories. Endocarditis prophylaxis is in so many subcategories. You have to have a major risk. A major risk. You have to have a significant defect, a very significant defect, and then a procedure that causes bacteremia. And a procedure that causes bacteremia. You have to have both of these things in order to be causing you to have endocarditis. So endocarditis prophylaxis, you have to have two things. You have to have a significant cardiac defect and you have to have a bacteremia causing procedure. For instance, you have to have a significant defect like aortic stenosis or mitral stenosis, aortic regurg, mitral regurg. And you have to undergo a procedure like dental work that gives you blood. Like an extraction, dental work with blood. You have to have a significant defect like a ventriculoseptal defect. And you must undergo a bacteremia-causing procedure, such as a hemicolectomy or cutting the GI tract or the respiratory tract that causes bacteremia. It has to be both things. It has to be something that is a significant bacteremia and a significant anatomic defect. For instance, if you have a significant defect like aortic stenosis, but your procedure that you're undergoing is only a cardiac catheterization or a skin biopsy, these would not count as a reason to get endocarditis prophylaxis. Because a cardiac catheterization is not supposed to be showering the body with bacteria. A skin biopsy does not shower the body with bacteria. A cardiac cath and a skin biopsy do not shower the body with bacteria, so they do not count as reasons to need endocarditis prophylaxis. Endocarditis prophylaxis is needed if you have both a significant defect and you undergo a procedure that causes a bacteremia. In order to need prophylaxis, it has to be both. If you have a significant defect, but you're going to undergo a procedure that doesn't cause bacteremia, no prophylaxis. The same way, if you're going to get your teeth taken out and cause blood, if you're going to get a hemicolectomy, if you're going to get a prostate biopsy, which causes you to be bacteremic, or get a transurethral resection of that prostate, but you have only a defect that is not significant, like a previous cardiac bypass, like a pacemaker in place, like a implantable defibrillator, like an atrial septal defect. Even if you have a hemicolectomy at the same time as a prostate biopsy is the same time all your teeth are being pulled out, that's a full day. But your anatomic lesion is only an atrial septal defect. You don't need prophylaxis because there's no place for the bacteria to stick. Like temptation for the holy man. There's no place for it to stick. You have to have both things. You have to have sin and a predisposition for those sins to stick to you. You can be surrounded by evil, but if you're pure enough, it will not stick to you. Yea, though I walk through the valley of bacteremia, I will fear no endocarditis. For my endothelium is intact, and no evil shall stick to me. I know that my heart is pure, and no evil can enter into it, if your heart is pure. Atrial septal defect, previous bypass, cannot give you endocarditis. A bypass is on the outside of the heart. And the last I checked, you can't get endocarditis from something that's on the exo. Nah. Pacemaker is not a predisposition. Atrial septal defect. Well, what is the difference in pressure between the right atrium and the left atrium? And the answer is that these are pretty much equal to each other. Well, what's the difference between the pressures between the right ventricle and the left ventricle? Oh, I don't know, sort of like 120 to 30. Woo, what a jet. Boom! Jet of blood shoots in there. Causes you to have damage. Causes you to have damage. Ready? Implantable defibrillator, pacemakers do not count as significant cardiac lesions to need endocarditis prophylaxis. Previous old endocarditis is certainly a risk. So what if somebody has atrial septal defect and aortic stenosis, mitral stenosis, a ventricular septal defect, and is going to undergo a GYN procedure, such as a vaginal delivery or a vaginal hysterectomy? Do you need endocarditis prophylaxis? And the answer is no. If you undergo a GYN procedure, such as a vaginal delivery, vaginal hysterectomy, you do not need endocarditis prophylaxis. Even if you have the defect, OBGYN procedures are not a cause of bacteremia. If you have a ventricular septal defect, when you have mitral valve prolapse with murmur, because mitral valve prolapse with a murmur is a risk. Mitral valve prolapse with a click only is not a risk. But even if you have mitral valve prolapse with a murmur and you're going to undergo a vaginal hysterectomy, a vaginal delivery, a cesarean section, a tubal ligation, a therapeutic abortion, an abdominal hysterectomy, GYN procedures do not cause bacteremia. Have you ever heard of Gardnerella endocarditis? You ever heard of someone dying of Gardnerella bacteremia? You know, the genetic element that would allow a woman to die in childbirth because of bacteremia or from endocarditis is not a genetic element that's going to be passed on to the next generation so well. So therefore, you're more at risk of bacteremia from one of your bowel movements than you are from a vaginal delivery, even with an episiotomy. You have more often bacteremia from brushing your teeth than you do from delivering a baby. Wow. You mean that little toothbrush is more dangerous to my heart than the big baby's head squeezing through my vaginal canal? Yep. Yep, that's correct. It means that 1% of the time, if you brush your teeth with a toothbrush that's too hard, you are going to get bacteremic. But the order of bacteremia from vaginal deliveries is less than 1 in 1,000. And even then, it's transient and doesn't even stick. OBGYN procedures do not cause endocarditis. What if you're going to have aortic stenosis, mitral stenosis, and aortic regurg, and you're going to undergo Sigmoidoscopy. Do you need prophylaxis for sigmoidoscopy? No. What about colonoscopy? No. Colonoscopy biopsy? No. Upper endoscopy? No. Bronchoscopy? No. And the answer is flexible scopes. Flexible scopes do not need prophylaxis. Flexible scopes do not need prophylaxis. Whether it's up or down or all around, do not need prophylaxis. Now, when you are going to prophylax, the prophylaxis for dental work with blood, dental with blood, is amoxicillin, 1 hour before the procedure. 1 hour before the procedure, a dose of amoxicillin. If you're penicillin allergic, it will be clindamycin. For GI and urinary procedures, it will be ampicillin or ampicillin and gentamicin. And if you're penicillin allergic, vancomycin. But remember, you need to have both types of things to need endocarditis prophylaxis. You need to have both a significant cardiac defect and a procedure that causes bacteremia so that the dirt can stick. If you just have the defect, what are we prophylaxing? We don't prophylax catheterizations and skin biopsies and GYN procedures. You would prophylax only if there was a bacteremia causing procedure. That's it for endocarditis. Fever and a murmur. And a murmur and a fever means to check the blood cultures. If the blood cultures are positive, get an echo. Vancomycin and gentamicin are your best empiric therapy. Switch the antibiotics based on the results of culture. Sensitive staph, oxacillin or nafcillin. Resistant staph, vancomycin, linezolid, daptomycin. Strep viridans, penicillin or ceftriaxone it was, penicillin or ceftriaxone it is. When you see strep bovis, you show them your buttocks. Colonoscopy, scope, bovis, buttocks, scope. Scope, because strep bovis is associated with colonic pathology. To need endocarditis prophylaxis, you have to have both a significant defect and a bacteremia causing procedure. If you combine one with the other, you don't need prophylaxis. I can take out all your teeth, but if all you have is atrial septal defect and a previous bypass, a pacemaker, look, you would think that an implantable defibrillator or pacemaker would be a need for endocarditis prophylaxis, but it doesn't predispose to endocarditis.